So before we start getting into ESTIM, we need to know a little bit about electricity first. So here's a very, very basic overview from the Starkey textbook. Electricity is a form of energy that exhibits magnetic, chemical, mechanical, and thermal effects. It is formed when the interaction of positive and negative charges meet. The positive and negative charges stem from protons and electrons. When there's an imbalance of electrons between the two poles or points, a force is created. That force is an electromagnetic force, which creates a situation in which electrons flow in an attempt to equalize the difference in charges. This creates an electric current, which takes the path of least resistance from a negative pole or a cathode, which has the highest electron concentration, to the positive pole, an anode, which has the lowest electron concentration. And for any electric current to occur, you must have a closed circuit for the flow. So now that we've learned a little bit about electricity, here's an overview of electrical stimulation. Electrical stimulation is an effective modality for stimulating sensory, motor, and pain nerves. There's no universal agreement on the parameters, but the use of ESTIM is to control pain and re-educate muscles. The therapeutic uses of electrical currents are control acute and chronic pain, reduce edema, reduce joint contractures, inhibit muscle spasms, minimize atrophy, facilitate tissue healing, and strengthen muscles. The means of delivering the electricity are through electrodes, and these introduce the current to the body from the stimulator or generator via electrode leads. These are what form the closed circuit between the generator and the target area, because like I said earlier, you must have a closed circuit for a flow to occur. And the placement of these, it just depends on how deep you're trying to go. If they're farther apart, then there's going to be more tissue stimulated. The stimulation is going to go lower, or deeper, I should say, and there are more parallel circuits formed. There are 5 stimulation levels of ESTIM, and these are all described with reference to the type of nerve that is stimulated. So for example, the first level is the subsensory level, which is from no output to right when the patient can first feel a small amount of electrical sensation, and this level does not have any therapeutic benefits. The next level up is sensory level, which the stimulation only depolarizes sensory nerves, and with this, in this level, you can see a slight muscle twitch, or the patient might be able to feel a tiny bit of a muscle twitch. Next level up is motor level, which is stimulation at an intensity that produces a visible muscle contraction, and at this level there shouldn't be any pain felt yet. The pain is felt in the next level, which is the noxious level, which is stimulation at an intensity that stimulates pain fibers. And the final level is the muscle fiber level, which causes an entire muscle fiber to depolarize, and this type of stimulation is only applied during long phase durations. And also, there is a cumulative effect as the intensity increases. So if you're in the noxious level, you're gonna see the muscle twitch from the motor level, and so on and so forth. Some of the contraindications of ESTIM are cardiac disability. So if the patient has a pacemaker or any heart problems, you really don't want to be messing with their heart like that. Interfere with the pacemaker, that could be really bad. Another contraindication is if they have any arterial disease. This could intensify some ischemia that they might have. Another contraindication is uncontrolled hemorrhaging. Another one is on the site of an infection. You don't want to contaminate your equipment. Another one, pregnancy. You don't want to electrocute the baby. Cancerous lesions. This could result in growth of the tumor. Exposed metal implants. This could result in a severe electrical shock. Some precautions of ESTIM are menstruation. Stimulation of the pelvic region could increase hemorrhaging. Areas of nerve sensitivity, so the carotid sinus, the esophagus, the larynx, the pharynx, near the eyes, upper thorax, temporal region. You might want to be careful around those areas. Unfused epiphyseal plates, so growth plates. This could interfere with growth and development of the patient. And severe obesity, excess adipose tissue, could provide too much insulation against any effective stimulation. So some evidence I found for ESTIM. The first article I found is Vagus Nerve Stimulation, a new tool for brain research and therapy. They said that the vagus nerve stimulation appears to be a promising new somatic intervention that may improve our understanding of brain function and has promise in the treatment of neuropsychiatric disorders. And before reading this, I didn't really know what vagus nerve stimulation was, so I looked it up, and according to the U.S. Epilepsy Foundation, vagus nerve stimulation actually prevents seizures by sending regular mild pulses of electric energy to the brain via the vagus nerve. It's kind of like a pacemaker for the brain. But back to the article, they did 2 double-blind studies that were conducted on patients with epilepsy with a total of 313 treatment-resistant completers. In this difficult-to-treat group, the mean decline of the overall seizure frequency was about 25 to 30% compared with the baseline. So data from the uncontrolled observations suggests that contrary to the tolerance effect, improvement in seizure control is maintained or may improve over time. In the initial uncontrolled clinical observation, and more recently a prospective study in a retrospective data analysis that suggests VNS or vagal nerve stimulation reduces depressive symptoms in patients with epilepsy, but the reductions are not entirely accounted for by reduced seizure activity. During the clinical trials of VNS for epilepsy, several investigators noted mood improvements in their patients, although decreased seizure frequency likely accounted for some of those improvements. But to conclude, the article is basically about vagus nerve stimulation, that it is already established as a clinically useful anticonvulsant in patients with resistance epilepsy and may have promise as an antidepressant treatment. The next article I found was the rehabilitation of gait in patients with hemiplegia, a comparison between conventional therapy and multi-channel functional electrical stimulation therapy. The proposed rehabilitation method was tested on a group of 20 patients that suffered severe hemiplegia secondary to a cerebrovascular accident, which is hemiplegia due to a stroke. The subjects were randomly assigned to one of 2 groups. One received 3 weeks of multi-channel functional electrical stimulation, or MFES, followed by 3 weeks of conventional therapy. The other group received the 3 weeks of conventional therapy and then the 3 weeks of MFES. The methods they used on the tests were: each therapeutic method was evaluated by measurements of temporal distance, variables in ground reaction forces, and by assessment of each subject's physical status according to the Fugel-Meyer evaluation scale. Recent kinesiological studies and clinical assessments showed that the MFES of the 6 main muscle groups of the affected limb can modify pathologic gait, accelerate rehabilitation, and enhance the endurance of the patient. Despite the good results, surface MFES is not routinely used as an orthotic aid because numerous electrodes need to be positioned, and that the patients find this difficult. It's just a really time-consuming thing. And so the final results of the study showed that there was improved performance of the subjects during MFES combined with conventional therapy as to just conventional therapy alone. The third article I found was titled "Muscle Atrophy is Prevented in Patients with Acute Spinal Cord Injury Using Functional Electrical Stimulation." So musculoskeletal atrophy is a serious complication of traumatic spinal cord injury which contributes to the development of secondary impairments in spinal cord injured individuals. It is hoped that the reinstitution of forceful muscle contractions utilizing functional electrical stimulation would counteract the atrophy in individuals with spinal cord injuries, thus decreasing the likelihood of costly secondary impairments. Despite the evidence, muscle atrophy appears to achieve a steady state within the first year of spinal cord injuries. And these reports suggest that the use of a portable handheld stimulator to reproduce muscle contractions is relatively ineffective in reversing disuse atrophy in lower limb musculature of individuals with chronic spinal cord injuries. There has been far greater success in counteracting disuse atrophy when therapeutic interventions are employed during the course of rapid atrophy rather than after atrophy has occurred. FES, or functional electrical stimulation, resistance training, has been successfully used to prevent disuse atrophy caused by immobilization. This study showed that FES could prevent disuse atrophy when training is initiated during the acute phase of muscle atrophy resulting from spinal cord injury. The fourth article I found was titled "Comparison of Isometric Muscle Training and Electrical Stimulation Supplementing Isometric Muscle Training in the Recovery After Major Knee Ligament Surgery." In this study, 8 patients undergoing reconstruction of the ACL were randomly allocated into 2 groups. The control group received a standard plaster cast and isometric muscle training. The stimulated group received a standard plaster cast, isometric training, and electrical stimulation during the recovery period. The patients were clinically examined with repeated muscle biopsies before surgery, 1 week after surgery, and 5 weeks after surgery at the time of the removal of the cast. The study found that the electrically stimulated group had better muscle function from a clinical point of view, and they were significantly higher than those in the control group. The study showed that the electrical stimulated group had better muscle function from a clinical point of view, and their succinate dehydrogenase activities were significantly higher than those in the control group. Electrical stimulation thus could prevent the fall in oxidative enzyme activity, which was noted in the control group. The results suggest that. The final article that I found was titled "Strength Changes in the Normal Quadriceps Femoris Muscle as a Result of Electrical Stimulation." The purpose of this study was to examine the effectiveness of an electronic muscle stimulator in strengthening normal quadriceps femoris muscles without the assistance of simultaneous isometric muscle contraction. So during the trial, both groups, the control group and the stimulated group, underwent isometric strengthening of the quadriceps femoris using a specified protocol, but the stimulated group also underwent daily stimulation. And the data from this test supported the use of the electrical stimulator as an appropriate device for strengthening muscles without voluntary effort. And on average, the control group strength increased by 2%, the isometric exercise group increased by 18%, and the electrical stimulation group increased by about 22%.